Hello, my name is Feroz Mahmood, and we'll be concluding this Trans-Septal Puncture workshop with some introduction, brief overview, and some cases for discussion.
And hello everyone, my name is Aidan Sharkey. I'm going to be joining Feroz on this panel where we're going to first give a brief introduction about some of the important topics we've talked about in the previous lectures. And then the main point of this panel discussion is to go through some cases where we performed Trans-Septal Puncture. We're going to go through the specifics of the cases and also highlight some challenges we faced in these cases and how we overcame these challenges during the case.
So Aidan, I think the way it works is that you ask the questions and I'll try my best to answer, so fire it off.
Alrighty. So Feroz, we've obviously talked a lot about Trans-Septal Puncture in all the previous lectures. However, there's a few questions I want to ask you that I think highlight the importance of doing this procedure. And let's start off with what seems like a basic question, but probably the most important question is, why is Trans-Septal Puncture so important? And why is it so important that we do this in a very precise manner?
Well, thank you very much, Aidan. That's exactly a very good question, because as you can see, in even this workshop, we paid a lot of importance and spent a lot of time on Trans-Septal Puncture, because this is kind of the baseline, or I'd say the procedure that sets the course or the tone of the rest of this thing. And as you can see, that we recently wrote a review article on the overview of the intra-atrial septum because of the ambiguity and confusions in terminology. And I highly recommend for all those people starting out on the journey of training in structural heart disease imaging to go over this article. So to answer your question in short, because the reason it's so important is that it is not a simple structure. Intra-atrial septum is not a simple structure. It is a false intra-atrial septum. There's a true intra-atrial septum, as you have heard in the previous presentation, and the implications of, first of all, going through the wrong location, that is going through the false intra-atrial septum, can be a pretty significant emergency and cause a significant septal hematoma and possibly a pericardial effusion. And then going through the wrong location in the true intra-atrial septum can be a very detrimental thing to the ease or the complexity of the procedure. Sometimes, as you will see in a case discussion, that we had to re-perform intra-atrial Trans-Septal Puncture, and that's why it is so important.
Yeah, and I'll just highlight what Feroz has said. I mean, I think you talked in your lecture about the embryology of the intra-atrial septum, and that really highlights how going through the fossa ovalis is the only point where you can be sure you're not going through an extracardiac structure, and this is why it's so important in terms of safety, performing this procedure in a safe manner for the patient, and also, as you said, in terms of making a procedure either easy or difficult is all reliant on where we cross and how we cross the intra-atrial septum. It can set up a potentially difficult case to be easy, or it can set up an easy case to be a difficult case.
Very well said.
So we've highlighted the importance of precisely performing the Trans-Septal Puncture. Now, you've obviously said that it's a very important procedure to guide. How do we train for this?
Great. That's again another good question. And I said the objectives of our training that we do for our structural heart disease fellows are sixfold: is to recognize the importance of precision, illustrate the value of a methodical approach, summarize the steps, relate the anatomical echocardiographic correlations. That's extremely important. And then appraise the procedure-specific approach to Trans-Septal. Like Aidan said, a difficult procedure becoming easy, and the other way around also if you choose the wrong location for Trans-Septal Puncture. And finally, the most important, to enhance communication to collaborate in performing a Trans-Septal Puncture. So this seems like 6 different objectives, but that's our purpose of our training when we do for Trans-Septal Puncture. And our purpose of training, as Aidan is proficiency and not expertise, which means we want you to be a safe pair of hands in guiding the Trans-Septal Puncture. Expertise is something that you gain with repetitive exposure at a very high level over time. So this is not something that you can acquire in a fellowship. A fellowship just, establishes your readiness to get involved in more complex procedures. So that's the end point of our training that we do in our septal puncture. And that's brings us to the PITLOC protocol that you are actually a co-author in. And that's the one that we follow for our Trans-Septal Puncture, which is a methodical approach towards training, which I'm sure somebody must have gone through in the workshop as well. So this is based on simplification, and that's the PITLOC stands for practice, identify, track, locate, optimize, and then cross. And each one of these steps has a value and a very specific process that it goes through. For example, practice part. Aidan, could you tell me? You've also written about it. What does the practice part consist of, and why do we need to practice on that patient before that procedure?
Yeah. So this is, potentially one of the most important aspects, because not every bicaval view is at exactly the 90-degree omniplane angle. Not every short axis view is at exactly the 45-degree omniplane angle. Each patient is different in terms of the orientation of the heart in the mediastinum. And so when you are performing the Trans-Septal Puncture, you need to very quickly, easily, and seamlessly transition between your four-chamber, bicaval, and short-axis view without losing sight of the needle. And this needs to be done, quickly, in real time. And so knowing exactly where you have your optimal bicaval view, your optimal short-axis view, enables you to very quickly go between these views, and so you're not looking for this needle, looking to obtain the best bicaval view while the proceduralist has his needle in the vicinity of the fossa ovalis.
All right, so that's the practice phase. That's the most important one. Next comes the identify phase. Now this is where we are showing the Trans-Septal Puncture needle coming from the IVC, going across the right atrium into the SVC. Now this may seem very simple in this patient who has a single, lead in the right atrium, but trust me, when there's a lot of traffic with pacing wires and sinuses, catheters in the coronary sinus, patients with pulmonary artery catheter, it becomes quite a challenge to accurately identify the Trans-Septal Puncture needle, because the next step in this one is essentially tracking the motion of the needle from the SVC along the thick portion of the interatrial septum into the fossa ovalis, and that again is a very important part to know exactly which needle and which catheter to follow, so that you're not looking at some other catheter and the interventionalist is inadvertently crossing the interatrial septum using something else. So that's an important part. So Aidan, is there any trick that you use to identify the tip of the needle?
Yes. So first of all, your needle should be continuously in view the entire time, and as the proceduralist is coming back onto the fossa ovalis, you want to identify the tip. Now, I don't know why, I can't explain it, but as we see here in this image, we see that the tip of this septal needle, there's a reverberation artifact coming from the tip. And we find that if you're having trouble finding the tip, if you try to look for this artifact, this is a very good, quick way to identify that you are actually looking at the tip of the needle that's being used to cross the interatrial septum, and you're not just looking at the shaft of the needle.
So we've gone through the tracking phase, and as you can see, at the same time the needle has moved considerably from the SVC into the fossa ovalis, and that brings us to locate. And locate part is identifying the indentation in the interatrial septum. Now that's actually the most critical part of it, because once you identify that indentation, you cannot let it go from the vision, because the proceduralists really do not have a tactile or haptic feel of when they're indenting, because it is so thin. They're purely dependent upon our determination of the fact that the septum is completely tented and not crossed yet. And that's when we begin to locate it even further. That was the mid-esophageal bicaval window, that was the superior inferior aspects. Then we go on and take a look at it in the antero-posterior axis to locate exactly where the needle is. And finally we optimize it. This is a fine tunings, of the septum to go superior, inferior, anterior, or posterior. This is where it's the most critical to maintain the continuity of the image, like Aidan said, not to lose it, not to have transitional images, because they're solely dependent upon this image of maximal tenting to optimize their septal puncture. And lastly is we determine the so-called the height, which is, to me at least, is a misnomer. That is the annular distance from the mitral annulus of maximal indentation before they cross. And again, as you can see, the caveat being that if you miss these two edges of the septum, you may think that the septum has already been crossed, whereas it has not been crossed. So you have to clearly demonstrate before crossing that this into the fossa ovalis is completely indented, and then you finally cross in real time under direct vision.
Thank you very much, Feroz, for going through the PITLOC protocol. And this is a very good protocol to follow when performing this complicated procedure. And just to piece all that together, we're going to go through a couple of images where we have performed a trans-septal puncture. This is a patient who had a previous left-sided procedure done. So as you'll see, they have a previous iatrogenic ASD. And our job was to perform this trans-septal puncture. We ideally wanted to not create a second iatrogenic ASD, so the level of precision required was that we actually perform this trans-septal puncture at the precise location of this patient's previous septal puncture. So I think we're going to go through a few images here. We're in the practice phase. We have identified the ideal omniplane angles for our bicaval and short axis views. We've also tracked the needle so we know it is coming from the IVC. We can see this patient has some other hardware in the right atrium. We can see the side of the previous iatrogenic ASD. The procedurist is now starting to come down onto the fossa ovalis. And as I highlighted in my previous statements, we're looking at the reverberation artifact of the trans-septal puncture needle here. And this is the tip of the needle here. And so we can see under color compare, we are able to track this needle as it falls into the fossa ovalis. So we've now moved on to our short axis view, where we're looking at the anterior posterior rims of the fossa ovalis, and again we're optimizing the view in terms of locating the septum needle at the exact point of the previous septal puncture. Here, using orthogonal plane imaging, we're looking at a short axis and a bicaval image, and again in this view we're able to see the tip of the needle in both the short axis and the bicaval view. We're now on to the optimization phase, where we're seeing tenting of the fossa ovalis, and we are identifying the exact location where we want to do our septal puncture. And then under continuous guidance, we will perform our septal crossing under continuous TE guidance. So that is a quick series of images that I think highlights a couple of things. It highlights, first of all, that in certain cases like this, we needed to cross the septum in a very, very precise manner. In this case, at the site of the previous septal puncture. And then it also shows the various aspects of the PITLOC protocol in action. And one thing I will say about the PITLOC protocol is that even prior to us beginning the septal puncture, another very important phase is the planning phase. And Feroz, I've done many procedures with you, and I know that we as a team with the interventionists, the echocardiographers, will sit down before any needles are introduced to the patient. We will decide, what is the plan for the mitral clip in terms of the plans for the clip, but also more importantly, what is the plan for the septal puncture. Do we want to be very posterior? Do we want to be mid? Or do we want another location on the septum?
That is an excellent segue and into what we'll be discussing next, and that is a few cases of trans-septal puncture where we needed precision and where we wanted to go. So let's go over those cases. So before we go on to do a few cases, we'll briefly go over the anatomy on the display of trans-septal, echocardiographic display. So the most common view is the mid-esophageal bicaval window, where you see the SVC on the right, the IVC on the left, the fossa vallis in the middle, the coronary sinus below the IVC, and this is actually the true fossa, and this is the aortic valve. Now, this orientation has been addressed ad nauseum by Aidan and myself, so we're not going to go into the detail, but the most important thing that we want to show you is through this graphic over here, and that is that the superior, inferior, and anterior and posterior are kind of arbitrary views that we could try to conform to our echocardiographic windows. They're not perfectly orthogonal, so they're not necessarily, that's why, seen exactly in the same locations as we are used to seeing perfectly orthogonal structures. So we already addressed that. But the most important thing that we want to show you is this image. We're very proud of this graphic. We created it all by ourselves, and this is the fossa vallis as we see with echocardiography. So the superior and inferior extents are seen in the mid-esophageal bicaval window, which is this one, which if you look at it is this one. The superior and inferior aspects are seen in the bicaval aspect of the window, which corresponds to this section. Then we go on to, back to the image that we're going. The anteroposterior arc that is going through the aortic valve somewhere over here, and posterior aspect is somewhere above the inferior vena cava, so that would be the anteroposterior aspect of the intraatrial septum. That's the aortic valve. That's the anterior, that's the posterior. That's the same thing being shown in the mid-esophageal aortic valve short axis view, and that's the section through the aortic valve, which actually more correctly demonstrates what we are looking at. Particularly the posterior margin is rather ambiguous what it really represents. And lastly, the misnomer, the height of the intraatrial septum, which means the distance from the annular plane, and that's seen in the mid-esophageal four-chamber view when you look at the distance of indentation that we saw in the previous image as well, and that is distance from the annulus is seen in this one, in this mid-esophageal four-chamber. So keep this diagram in view, and we'll go over this orientation in a few minutes when we look at all these cases. So let's go over the cases. So this is our case one. These are actually simple cases and only one that we have a little complicated over here. So let's go over case one. This is run-of-the-mill P2 flail segment, which is obviously an anteriorly directed jet. The complication was, as you can see in this patient, pretty significant shelf of calcium in the area of the grasping, which means the leaflet had to be grasped at the side of the flail because that's exactly where you want the delivery sheath and clip to be devised, and also minimal motion of the clip under the leaflet because there was a risk of dislodging this chunk of calcium. So while it may not seem intuitive, but I'm trying to drive home the fact that we wanted a very specific and a very sharp and a precise septal puncture which would drop the sheath directly at the site of the septal, of the P2 flail, so that we had to have minimal manipulation of the device under the leaflet. So you can see how this whole precision comes into play that can impact the quality of the procedure. So you can see these are the views. This is the mid-esophageal bicaval with the coronary sinus. This is the AP view. So if I look at the bicaval window, this is just for reiteration, this is the views that we are looking at. That's the superior and anteroinferior aspect of the septal puncture that we're looking at. The same goes for the short axis view. This is the aortic valve. This is the anterior aspect. And when you look at it, we are looking at the anterosuperior and somewhat posterior inferior margin of the intraatrial septum. And then that goes on to give us the modified kind of a 5 to 4 chamber view in this specific patient, trying to give us, again, the anteroseptal to the inferior view of the intraatrial septum. Now, having said this thing, You can see that this patient also had what seems like is a little foramen valley over here. And would you agree with that? You can see, well, the scale is not exactly set, but the problem with this one is that when the patient has a patent foramen valley, the needle has a tendency to cross the path of least resistance. Is that what your experience is also?
Yeah. And it's very important. I mean, we can see in this patient has obviously very high left-sided pressures, and so you may not see colour flowing across the fossa ovalis or the patent foramen valley. So it's very important to look at the anatomy. And so let the proceduralist know that there is a high degree of suspicion. Even if you can't demonstrate it with colour, let the proceduralist know that there's a high suspicion for the presence of a PFO.
So,
and another question for Rose is, on your previous images, the bicable window that you've shown, how do you differentiate, or what trick to use to differentiate between the coronary sinus and the IVC?
That's a great question. So, in one of the most important things, the two anatomical structures that I keep in mind is, number one is the septal leaflet of the tricuspid valve, and the other is the eustachian valve. So, the presence of eustachian valve, while not that prominent in this patient, is a clear indication that this is inferior vena cava that is draining into it, and the presence of the septal leaflet of the tricuspid valve below this opening implies that this is not the inferior vena cava but the coronary sinus. So that's an important distinction between the two of them. So there we go. So in this one, as you can see, that this is the true all the variation of the septum that we saw, the superior, inferior, posterior, interior. And now we are going in the tracking phase, and this is the fossa ovalis, the patent foramen valley that we want to avoid in this patient. We are seeing the septum in two different orientations. We have identified the needle in this view. Needle is identified again. We are tracking the needle here. The needle is coming back. Now, this is the most critical phase because you're indenting the thick part, which is the false intra-atrial septum, and if you puncture here, there's likelihood of either going in the periaortic space or the extracardiac space in and around this big sinus. This is the reverberation artifact that Aidan talked about that we need to track. And now, as you can see, quite predictably, this needle initially indented the patent foramen valley, and that was something that we wanted to avoid in this patient. Then we moved further posteriorly, and we crossed it pretty significantly posteriorly because we wanted to avoid the patent foramen valley in this patient. So based on this location, I would suggest that our septal puncture was very posterior, which is very posterior, and very inferior in this one, somewhere more inferior. So this is how we kind of go over this case. So, and this is the mitraculate device was deployed, and we were able to reduce the regurgitation from 4+ to trace, and quite amazingly, we did not dislodge this chunk of calcium, and it ended up very well. Let's go to case number 2. Now, this is just a little bit more complicated. This is a 60-year-old female in shock. Now, these are indications that are not typical indications for edge-to-edge repairs, but with patients becoming more and more sicker and surviving to these locations, these points in time when they have acute MIs with severe MR and a prohibitive risk. This offers a Hail Mary situation which sometimes works very well. And this was again the same situation, a patient who had an acute MI, had numerous cardiac surgeries in the past, and now was a prohibitive risk for surgery. So we took her in for emergency edge-to-edge repair, and as you can see in this one, this is a central jet as well as a posteriorly directed jet because of retraction. Again, you see this in this patient. This is the SVC border of this patient. This is the AP border rim of the septum. You look at this one again. This demonstrates the superior-inferior aspect. You go back on this one, and this demonstrates the anteroposterior aspect of this patient. You go back. You go on to the next one. We are again tracking this needle, and now this was a rather high stakes case because the patient was also an intra-aortic balloon pump, and we had to deal with this thing very quickly. And based on these two views, you can see that the target area is very small. So this is somewhat difficult and somewhat, easy also because there's not much finesse you can do this one, but also difficult because you have to, time it right so that you go across the right place. So we tried to do a first attempt at trans-septal puncture, and we were, as you can see, we were able to track, but we were unable to locate the needle into the fossa vallis because it was so small that it kind of slipped from the superior limbus to the inferior limbus without indenting the fossa vallis, and that was becoming somewhat of a problem. Every time we tried to indent it, it went through the patent foramen valley, and that's something that we did not want to do because we want to take one shot at it and be done with this thing and move on with it. This was our second attempt. Now we were a little bit more careful, and as you can see, we are tracking this indentation. And like Aidan, you pointed out, this is like one lighthouse that is available for your procedural guidance that tells you that you're not sectioning the needle somewhere in the middle, but actually looking at the tip, and that's this reverberation artifact. And as you can see in this one, they brought this tip very masterfully in the middle, and we maintained this entire continuity of image and not without going into, losing this imaging during the process of septal puncture. And then we tracked it back. We were able to indent. We were sort of much inferior, and the height or the annular distance was adequate for us. Then we optimized it and then crossed it while we were optimizing this patient. And as the final result, you can see, sorry about that, so based on this image, you can see that it's somewhere in the middle, rather posterior, okay? More inferior than posterior, and quite predictably, if you look at this graphic, our septal puncture is more inferior than it is posterior, and we got an exact location where we wanted this septal puncture to be. And as you can see, we had deployed this in the exact location where the flame was, and the patient, while the follow-up on this one was that intra-aortic balloon pump was removed the same day, was weaned off the inotropes and extubated within 24 hours, and we had a great result.
Very good. I think that case highlights two things for me. First of all, obviously, like you were pointing out, the precision, because your target area in this case was, was so small, so it needed, very, very precise guidance. But second of all, I think to me the most important thing is that if you are not achieving the optimal imaging or seeing the transseptal needle in your initial images, there's nothing wrong with doing a reboot, starting again, putting the needle back into the SVC, and starting the PITLOC protocol from the very start, rather than trying to keep finding this needle somewhere in the vicinity of the fossa vallis. Just take a reboot, start again, and just very slowly, in constant communication with the proceduralist, track that needle as it's coming down onto the fossa.
Perfect. So that brings the case 3, a short case. And this, Aidan, exactly what you pointed out, is a case that requires precision. If you see this en face view of the mitral valve, this is a P3 flail with anterolaterally directed jet. And as you all know, that commissural, either on the anterolateral or posteromedial commissural clips are very difficult to place and require a very high degree of precision. Again, this is the coronary sinus, like you pointed out. This is, you do not see the eustachian valve, and as you can see, this is the IVC. You're beginning to see the eustachian valve, so that brings in that point, and this is the anteroposterior aspect. Back to again, to reinforce, this is what shows is the anterosuperior and posterior aspects. This is the coronary sinus showing over here. So obviously this section is between superior and more anteroinferior. And if you look at this one, where you're seeing the IVC here, this shows a more superior inferior directly as opposed to that one. So there's a slight difference in this one when you look at it here. Well, that brings us to the conclusion of the case discussion of trans-septal puncture cases. I thank you, Dr. Sharkey, for being a panelist, and I hope you find these cases interesting and educational. Thank you and good luck.